Hello and welcome. This is Palan, and you are listening to Stuck in the Middle, a podcast that looks at the psychology of uncertainty, the quiet strength of ambivalence, and the choices that shape who we are. If you are navigating life's uncertainties, those moments of doubt, change, or growth, then you are in the right place. Because sometimes life isn't black or white, it's lived in shades of gray. We believe that in the context of ideas, we find clarity and the perspectives to move forward. Join us in this ongoing, meaningful conversation. Subscribe now and tap the bell icon. Hello, good day, and welcome to the episode Healthcare Under Pressure, Who Pays the Price? We have a guest who has been at the forefront of one of Malaysia's greatest healthcare crises. Healthcare has long been one of Malaysia's pillars. We take pride in accessible and affordable healthcare, where ordinary citizens can just walk into a general hospital, a public hospital, and receive care at heavily subsidized rates. But today, the strain on the system is becoming harder to ignore. Public hospitals are overcrowded. Our doctors and nurses are really under terrible stress and pressure. Insurance premiums are increasing. Private healthcare is getting more and more expensive. And more Malaysians are beginning to ask a difficult question. Can the system continue to function the way it has always functioned? What makes this even more complex is in the last couple of years, our healthcare budgets have increased, but now I think the budget in the last financial year was about 46 billion, and now that's taken a big hit in the recent announcement by the government because of the backdrop of the Iran-US war. So can healthcare remain affordable, accessible, and sustainable all at the same time, simultaneously? Today, we speak to someone who stood at the center of Malaysia's gravest healthcare crisis. Sri Dato Dr Noor Hisham, Chancellor of University of Cyberjaya. He was also the former Director-General of Kementerian Kesihatan, the Ministry of Health, led the nation's response during the COVID-19 pandemic crisis. He has seen firsthand the realities inside the system, the pressures and the trade-offs, and the structural challenges that don't always make headlines. So this conversation goes beyond statistics. So Sri, we are here to talk to you about really understanding what's happening inside Malaysia's healthcare crisis and what we as Malaysians need to do to prepare for the years ahead as we grow into a more and more of an aging society as well. So why do you think, Sri, the healthcare system is under pressure, as most people think?
Well, we started, first and foremost, I think, when we discussed about healthcare, we started way back in 1960s and 70s, whereby we focused on health as an equity in terms of accessibility, affordability, and as a right for our population. And more important, we focused then on primary care. And we are on the right path at that point of time because our intention was to lower the infant mortality rate, and etc. But now things are changing because the disease that we encounter in our hospitals and clinic, and the cost of healthcare is increasing. So now I think we look into our healthcare system. In 1970s, we have a dichotomous healthcare system, the public and the private, to address the needs of our population. But I think we also need to re-look back again our healthcare system, whether it's able to sustain in the near future. Even today that we can see, and last 10 years we already prepared, and we have maybe perhaps more than 16 consultation with the respective organizations and to get in terms of the projection of the healthcare system to transform our healthcare system. But we've been discussing this for more than 45 years actually, to look into how our healthcare system, can be sustainable in time to come. But now I think we need to really transform our healthcare system so that we can meet the needs of our population. So this is a big challenge in our country.
Then Sri, the government took a great initiative to create a white paper on health.
Right.
What direction should it take? And the former two health ministers were the co-chairs. What do you think came out of that white paper?
So I think, why do we need a white paper? Because we realize that, when we discuss about healthcare transformation for the last 45 years, when the new government comes in or the new minister comes in, then there will be new ideas and, and perhaps sometimes override the previous government or minister's planning. So when we have a healthcare white paper tabled in Parliament, approved by bipartisan support of parliamentarians, so regardless of who is the minister today or in future, or who is the government of the day, but then the white paper is available, then we can actually continue the agenda of healthcare transformation. Because healthcare transformation is not it's a long-term planning, not a short-term.
Sure.
So that's the reason why I think it was tabled in Parliament and it was supported by a member of Parliament. Everyone agrees that we need to transform our healthcare. Now the issue is, how are we going to transform our healthcare system? And until today, although the healthcare white paper has already been approved, but we need to look back in terms of the implementation of the white paper. Whether we have a strong political will to implement it, and obviously there's a lot of issues and challenges to be addressed in implementing the white paper.
So Tansri, you talked about increasing healthcare, and then of course we talked about the white paper because we want a plan, a long-term plan, some kind of a path towards healthcare transformation.
That's right.
But whenever we talk about increasing healthcare, we talk a couple of things. There are some reasons why healthcare costs go up. And that's one of the reasons I think Malaysia a few years ago, or maybe to correct myself, many years ago, had the private healthcare also come up so that it could support.
Yes, right.
But one of the biggest challenges is when we talk about increasing healthcare, it's about the cost of medicine, drugs, right? So we have generic drugs.
Yes.
And we have the issue of patented drugs.
That's right.
So how does Malaysia manage it? Because sometimes healthcare should be for all people, irrespective of their status or wealth, which Europe has done very well.
Yes.
And I believe, according to critics, US has not done that well, even though Obamacare came by. But in Malaysia, I have found that most of the time, it's just not possible because in the public healthcare, we generally go towards generic drugs, but some drugs are very expensive that even the public healthcare system cannot afford. So how do we go about those kinds of costs?
Well, when you look into healthcare expenditure, in public sector and private sector, total expenditure probably about 4.1% or 2% of the GDP is still underfunded.
Right.
Even we have the private healthcare system, but the issue is how do we optimize the two systems to complement each other. But now I think when private healthcare been introduced in 1970s, it was said that those who can afford goes to the private and those who cannot afford come to the public. But I think then you can see that the workforce will be affected because, most of the doctors and even nurses now, specialists will resign and join the private sector. So that is something that we need to address, because I think not only the services, but in terms of the funding.
Sure.
And you cannot deny those who can afford, because they are in the private sector. They also come to the public sector when the service is good, for example.
Sure.
Because they are the one that pay the income tax, and then obviously they are entitled to be
Sure.
treated in the public
Sure.
sector. But the poor patient do not have access to the private sector.
Of course.
Yeah, then they basically comes to the public hospital only. Then you can see the public hospital, there will be congestion in the public hospital. The issue is, how do we integrate the two systems together, complement the two systems together? And to complement the two systems together, we have to address the funding in terms of the poor patient
Sure.
going to the private sector for treatment. I mean, if they have the means to go, some form of health financing and etc., then probably you can basically optimize the two systems, public and the private healthcare system. If that's the case, then the patient will be driven by quality of care.
Of course.
If the quality of care is good in private, they'll go to private. If it's good in the public, they'll go to public. So you can actually optimize the two systems together. But that's the big challenge. Now, the issue is the funding. How are you going to
Sure.
address the issue of funding?
Sure.
Hi everyone, I'm Adam and welcome to the University of Cyberjaya, or UOC. If you're looking for a university that's truly on the world stage, you've come to the right place.
So, Tan Sri, but then the most important thing here is, I see like most of these private care patients who go to the private care, they find that if they make a claim, the insurance companies increase their premiums.
Yeah.
And then it becomes so unaffordable.
That's right.
Obviously, from an insurance company perspective, we understand the more people come with claims, the way they got to make this sustainable is to increase premiums.
Right.
But sometimes it's horrifying from the stories that I've heard. Premiums have been increased twice or thrice, and therefore they just surrender and say, hey, look, let me go back to the public healthcare system. And that puts a lot more pressure on the public healthcare system.
Right.
And the ministry says, look, we can't afford more doctors, we can't afford more nurses, and we can't retain them as well.
Yes.
So how do we deal with this issue of continuously increasing costs? And the public health care, obviously, because of funding, people don't give you a Lipitor, they give you a generic drug which is similar. But then sometimes it works, sometimes it doesn't work. I can't vouch why it works and why it doesn't work. And also sometimes we found that between two public hospitals, one hospital gives you better care, and therefore there's a huge congestion there. And the one that doesn't provide the level of service is just kind of languishing. So how do we deal with a problem? Looks easy, but it's not easy. It's serious.
Well, the last 40 to 50 years, healthcare actually has evolved tremendously with technology, advance of medical devices and etc. So basically, the costs will increase. Escalating costs in healthcare, you cannot deny that. But the question is, how do we mitigate that cost?
Yeah, exactly.
So I think because of the technology, because of the advent of certain investigation and also medicine that we use, so now the issue is, how do we balance it? So I think we cannot deny the fact that, the non-professional fee, for example, and the professional fee. Professional fee is being regulated, and for the last 23 years has not been reviewed.
And exactly, and that's why the doctors are saying, hey, look, the costs have gone up. It's all about inflation, but so don't put the blame on us as we are increasing the costs.
So in terms of the professional fee, it still remain the same for the last 23 years. Meaning, if you were to do a surgery today, surgery A, you are paying the cost 23 years ago.
To the professional.
To the professional. But the non-professional fee
has gone up.
And that's certainly, cost of living has gone up, etc.
Sure.
So that's one. Second is the technology, because now with new drugs, it's very expensive. For example, hepatitis, when we treat hepatitis, when they introduced the drug in 2015, a combination, Sobovir and Dacladasvir. The combination treatment costs about 80,000 US dollars.
No way anybody can afford
No
it.
way that we can afford. But the lower middle income country being given a generic drug. But we are not rich enough to be a developed country to pay for the drug, and we are not poor enough to be in a low middle income country. So we are in the middle income track.
Sure.
And we negotiated with the company, and then the company reduced it to about 55,000 US dollars. Even then, it's backspace. So we have no choice but to have a creative ideas and innovation to bring down the cost of the medicine. So what we did is basically we use compulsory license to break the patent and to bring down the cost of the treatment right down to 300 US dollars. When I was actually in office, basically we really looked into the whole ecosystem of healthcare.
Sure.
Number one, because of the public sector and private sector, we must have a retention package so that our specialists will continue to serve in the public sector. So there are various initiatives being done and address the issue. For example, we give them scholarship for training, postgraduate education, sabbatical, and so at least even a time break for them to do clinical research and to attend conferences and etc. And certainly when we look into the retention package, we also need to consider in terms of posting. Most of the doctors wants to be in the urban area.
Sure.
Very few wants to go to the private area. And there was a saying that, if you know someone, the DG, or someone in the Ministry of Health, then you will remain in the urban area. If you do not know them, no cable, then you get a one-way ticket to the the Sabah and Sarawak, and you don't know when you are coming back.
Right.
So there's a perception of, in terms of implementation. So what we did is we try to encourage those who have done their housemanship in Klang Valley, they have to go out. Those who have done their housemanship outside in a rural area, they'll come back. And with that ecosystem, then you don't mind going to Sabah and Sarawak for 1 or 2 years to get the experience. And we give them priority. When they apply for masters, postgraduate, they'll get priority.
Right.
And they'll come back 2 years later.
Right.
In the meantime, they get the experience, hands-on experience, etc. So we try to balance the two. Sure. We also introduce the lean management. This comes under Pemandu, under Sri Dato. So in terms of how can we optimize the resources that we have without increasing the quantity or even the service. Sure. So looking into, for example, radiotherapy in Sultan Aminah Hospital, Pandan Hospital, Sultan Ismail Hospital, for example, the waiting queue was about 4 months. But, looking into the processes, we can actually cut down to about 3 weeks. So there's a lot of initiative being done. One of the initiatives that we also done is the waiting time for cataract surgery was about 6 to 9 months. So what we did is with partnership again, we embrace partnership with an organization, Majlis Agama Islam Wilayah Persekutuan.
Sure.
They have a building, still belongs to them. We provide the services. And we realize that when we operate in the general OT, the maximum cataract operation we can do is about 7 to 8 cases. But when we focus one operation, that the efficiency increased 100%. That means we can do 15 operations a day.
Okay.
So we have 2 operating theatres in a shop lot next to a car yard, next to a coffee shop. And this is daycare surgery. We can do 15 one theatre, 30 operation a day. The maximum of 30 operation. So with that, we cut down 9 months waiting time to almost about 2 weeks. And that is again been recognized by WHO. We have done until today more than 35,000 operation, and the patient only pay 102 ringgit for the service. And also, if they can't afford the lens, we got sponsors from various organizations, Standard Chartered, for example, and a lot of donation for the free lenses for them. And it's still running. And WHO have actually used this as one model to address in terms of how we can provide quality care, at a high impact, good outcome at reasonable cost. And we also monitor the performance of the surgery in this center in Jalan Ipoh, in
the
Shop Lot,
quality, yeah.
in terms of the quality. And we realize that the outcome is better than any private or public hospital.
Right.
In terms of numbers, in terms of quality. So this is the framework has actually been adopted by WHO. Even the regional director of WHO Western Pacific region came, and he was surprised to see that we can implement this.
Right.
Again, this is some of the initiative we have done in terms of optimize the resources that we have in the public sector, and we have introduced the lean management in terms of, because we know the funding is limited. In 2017, I made a statement, we are underfunded. You look at the GDP, we are underfunded, we are understaffed. Until today, we are still understaffed and underpaid. Our doctors are underpaid, our nurses are underpaid, and our, we are overstretched, overworked, overstretched, and our facilities congested.
Sure.
Again, with limited resources, how do we optimize? That's why the lean management came in. Yeah.
Thank you. So we talked about the white paper to be a guideline document, whoever is in power, a bipartisan approach. Then we talked about cost. But I've got 3 points down there. One is, I still remember Tanji talking about this, the cost of some of the drugs for oncology. Just amazing. It's just so expensive. And I've also heard stories from people, they've got $1 million policy, but that doesn't sustain them even for 2 months of cancer treatment because it's just simply unaffordable. So the question number one is, how do we manage those extreme examples? Okay, it's not, let's say, it's beyond the standard deviation, because standard deviation, we talk about some of those day-to-day cases. But then, of course, as one of the top surgeons, you know that there are cases outside of the standard deviation. Second, of course, you talked about this example that WHO really recognized the cataracts, and then, of course, it became $102. Outcomes were better, if not similar, to public healthcare hospitals. I know that the Malaysia was also trying to do the offtake with the private partners. How did that work towards reducing costs? That's the second. And the third one is, does it make sense for Malaysia to bring about something like Obamacare? Everybody buys an insurance so that everybody deserves, gets what they deserve, good healthcare, and they get it.
Well, if you look into new cancer treatment, it's very expensive.
Right.
And locally, not only locally, but then regionally and globally.
Yeah.
But in WHO, for example, we try to address this issue. How do you price the cost of, the cost of medicine, especially the new medicine? We can understand that if you invest in the research, you want to gain back the funding.
It takes a long time to commercialize it.
But we also realize that, many big pharma companies, they actually buy over smaller companies, and then then they make profit from the smaller companies. So we discussed about price transparency, price control in WHO. But obviously, there's a lot of resistance with regards to that. But more importantly is that what choice do we have actually? Now, I think most of the medicine, if we try to have a generic, but generic, you must have a BE study, bioequivalent. And if the bioequivalent is as good, then only we actually adopt and then use generic. Most countries are using generic now. And one of the reasons that recently you can see the government wanted all the patients that been treated in IJN to come back to the public sector. One of the reasons is because in IJN they're using what they call that original.
Yeah.
And the cost saving is actually almost 100 million for follow-up patient. If you were to use generic, it would be much cheaper. That's the reason why I think cost saving about 100 million. But most countries now, you are using a generic.
But is there a qualitative difference between the two?
Well, you say it's a branding. right? So, but in terms of bioequivalence,
Yeah,
we have to look
outcomes,
at outcomes. The bioequivalence is acceptable. We can actually use.
Sure,
Most
because
countries are doing
because
that.
sometimes
So
the perception out there is
perception is different. So we have
patients
to address.
basically say, "Oh, I tried Lipitor; it was very good."
Yeah.
I mentioned this because I use it. It's not because
yeah.
I am branding Pfizer.
Yeah.
But sometimes people come and say, "Oh, I took a generic drug from India or
So
Indonesia."
we need
and
to
it didn't
manage the
work."
perception, but looking into data in terms of bioequivalence is almost the same. Right.
Because the pricing is just incredibly
Exactly.
amazing.
Yeah.
So one of the challenges is the variation between countries.
Right. So there are a lot of things that we can do to mitigate the cost of medicine. Obviously, I mentioned earlier using the compulsory license. So far, we have used for HIV and we have used for hepatitis C. Then second, I think a pooling of resources. So if we have big volume, we can negotiate for better pricing. So for example, in the vaccine, EU procure the vaccine for COVID-19 on behalf of 30 countries. Bigger volume.
So
But smaller countries, Malaysia only for 30 million, but Brunei, for example, that's the price that they pay because no volume, right? Very small volume, so the price will be much more expensive. So if we can use in terms of pool procurement, not only for local, but we not only for Ministry of Health, we already done it in Ministry of Health. In fact, before I retire, 3 ministries, so we have 82 medicine pooled together in 3 ministries: Ministry of Health, Ministry of Higher Education, and Ministry of Defence. Cost saving was 179 million. Only in the public sector. Have we actually, and then we have 2 sessions of discussion and engagement with the private sector. So if we can pool together with the private sector, it'll be much more cheaper. But if we can use the ASEAN platform, for example, huge, you can bring down the cost.
All of the 11 countries can buy together.
Yes, right. So we actually have a meeting in NUS. I was invited to talk about it, and certainly there was a discussion about pool procurement using the ASEAN platform. But again, we have a trust issues and things to be addressed. Within our neighbors, So I think we hope that we can use the pool and increase the volume and then bring down the cost.
So how did that offtake model work in Malaysia?
And then offtake, for example, if you're manufacturing, for example, locally, so the government will give you the incentive of maybe 2 years, 2+1, for example, to give you a jump start, but encourage the production locally. And then that will reduce the cost.
But in terms of like your example of the cataract, let's say getting another private hospital which is just starting out to do scope, colonoscopy or gastroenterology. Or let's say, for example, there are many other things that you'll be able to do and take the pressure off the public healthcare system. How did that work out in the ministry?
So I think this is a partnership. We look into partnership. And we learned from the pandemic COVID-19, how do we optimize the resources in the public sector and private sector? Cataract is one example that we partner with another organization so that we can mitigate the congestion in the public sector. So it's important for us, to look into, how to decongest the public sector.
Of course,
But to address the issue, funding will be number one. Who is going to pay, right? So at the moment, I think HSOP, for example, is hospital outsourcing services. We have a long queue, for example, for cardiac surgery in the Sri Dato Hospital. The government have allocated a certain amount of funds to outsource the patient to the private hospital. So, and that hopefully can reduce the congestion in the public. The waiting time, I was told, in Sedang Hospital is almost about 1 year or 1 year for cardiac thoracic surgery. So by outsourcing to the private hospital at the negotiated pricing, and then I think complex cases and etc. So you can reduce the congestion.
Some common procedures, daycare procedures like endoscopy, colonoscopy, all those things can be outsourced, right?
That's
and I knew that one of someone that I knew went to one of the public hospitals, and they had an 18-month waiting for to do an angio. For example. So that's a long wait. So moving on to the third one, what do you think, Tan Sri, about something similar to a national insurance scheme
Yeah.
like Obamacare?
Yeah. So when we talk about outsourcing now, the government is paying for the patient going to
Sure.
the private, but the government is not the insurance company, right?
Yes, exactly.
So we need to have a national health financing in place, not private financing, but national health financing. Basically control the pricing. Otherwise, you can see escalating costs in
Yeah.
terms of the premium
Yeah.
and etc.
Yeah.
So if the government is controlling in terms of health financing, then everyone, in citizen will be under this health financing. Now, for example, documented migrant already there's an insurance scheme for them. Yeah.
Sure.
So now, what about our citizens? So if we can do that, then the citizen can crisscross within public sector and private sector.
Of course.
We need to tweak a bit here and there. In the private sector, for example, we are looking at the payment, I think, coming from the insurance company and etc. So, like, we in UCSI, I think we started a public wing. In the public hospital, we already have the private wing. That the private wing is to retain our doctors after office hours, for example.
Just like the model,
That's right.
UMSC,
That's right.
so that you can keep them
You
at
keep
least,
them-
give them 8 hours private
Exactly.
time. Yeah.
And we are doing it after office hours or Saturday and Sunday, whereby we do not.
Otherwise, it'd be impossible.
That's
to
right.
retain.
So do not compromise in terms of treating poor patient, for example. So this is after office hours and weekend. So we encourage them to use our theatre and
Sure,
etc. So that's been done under full paying patient before, and most of the university hospital also have that concept.
Yes, I think
But now in a private hospital, we want to start the public wing. We need, meaning, we know that for certain patients,
Your corporate social responsibility.
corporate social responsibility bring down the cost as well if they are not insured, for example.
Sure.
So if everyone is insured, then you can crisscross between public and private, and then it will be driven by quality of care. The quality is good in private, they go to private. Good in public, they go to public. So
Because the perception, just moving on slightly, an organization you are very involved with. I know that Tan Sri has done so much. You have been with UCSI, you have been with IJN.
yes,
And of course, public criticism is, the public compliment is, IJN has done so well. The outcomes are just incredible. And some of the results that have come out become a real center for excellence.
Right.
But the criticism is also that it's not cheap, IJN. And the perception is, well, I know because I go there for my annual checkups, it's private,
yes,
but people think it's government.
right.
And therefore they say, well, there's not much of a difference between, say, another private healthcare and IJN. And I know Tan Sri is an IJN, so maybe you can shed some light.
Well,
on
need
it.
to address IJN is Sendirian Berhad. It means it's a private entity.
Yes,
But the fundamental is that when IJN was established,
It
there
was
is actually a 60-40.
Okay,
60% for the public patient
Okay.
referred by the government and maximum 40% for a private patient. But at the moment, we are running about initially about 20-80. 80% is a public patient.
Right.
And now that because follow-up patient has been withdrawn,
Right.
and there's no choice, but IJN have to focus on the private patient. So we increased the pool of private patient to about 30.
Okay.
30%.
70-30.
70% is still public
Oh, so
patient.
it's still, so the waiting times are managed.
Yeah. In the private sector, 30%, the fee is the cheapest. I have engaged with the insurance company in Malaysia.
Malaysia.
Yeah, it's cheapest. That means, and it has not been reviewed for last 20 years. And in the public sector, the fee from referral from the MOF is paying is also have not been reviewed for the last 23 years.
Okay.
So which means you do the surgery bypass operation, you're paying the fee 23 years ago. And obviously we wanted it to be increased, but we understand, although we are not charging according to the fee schedule,
Right.
but we are not making a loss. But I think
Sure.
we try to break even. But there will come a time that we may not, and we will make a loss in that sense. That's the challenge that we have.
So, the Ministry of Health Malaysia has got this, I think the term is Malaysian Health Tourism Promotion
Yes,
Board,
yes.
something like that. And like Thailand is promoting health tourism.
Yeah.
Turkey has taken over the aesthetic business.
Yes. Yes.
India is now taking over most of the cardiothoracic cases at some unbelievable prices.
Yeah.
Now, of course, quality differs and the nature of healthcare differs. But how do we attract healthcare tourism into Malaysia
Right.
when we ourselves have a challenge?
Yeah.
I know private healthcare providers are doing that, but let's take, for example, IJN. That's a source of revenue that you could use in order to mitigate the costs
Yes.
for Malaysians.
Right.
But how do we go about when the system is already under pressure?
Yeah, the system, the public sector is really under pressure, but we are looking at the opportunity in the private sector.
Right.
So the private sector, and then our cost is still reasonable in this region. And more important is good outcome, a high impact at a reasonable cost. And that's the reason why we are pulling in terms of tourism,
Tourism in there.
to health tourism
But
in
would we
Malaysia.
still be competitive to Thailand or India in certain
Thailand
areas?
started much earlier, and I think there's a lot of things that we can do to increase the demand of health tourism in the private sector.
And this would be more in subspecialties, right?
In certain areas, for example, in cardiac surgery, I think look at our private hospitals, because one of the private hospitals in Penang, 80% of their patients coming from overseas and cash paying patients, for example. So because we have been known at a very reasonable cost and the environment, etc., and good quality. So most important is driven by quality at a reasonable
Of course,
cost.
and of course the outcomes.
Yeah, the outcomes. So I think we are as good, if not better, especially in IJN or even private hospitals, but our cost is very reasonable.
At UOC, we believe your journey is more than just academics. On level 1, you'll find our Student Support Hub, your dedicated place to speak up and get help with anything university related, from academics to campus life. Right here is the Career Services Center. Whether you need help with CV reviews, career coaching, or interview prep, our team is here to support you every step of the way.
Tanshi, we talked about costs and we talked about generic costs, we talked about healthcare congestion in the public space and costs in the private space, as well as increasing health premiums. But one more very significant pillar that I'm sure you have been very conscious about during your term as Director General. As an educator, I've been very conscious about it. And I think that's the talent bank.
Yeah.
And we have situations where CEOs of private hospitals come up to us and say, could you please give me 5 nurses? Otherwise, I'll have to close down some beds because I can't manage the bed-nurse ratio, etc. But unfortunately, Dhansri, all the nurses are either sponsored by some of the big players.
Yes, right.
Of course, the Ministry of Health has their own training systems, but we're talking about the other providers. And all the hospitals come and sponsor them from year one.
right.
And they are gone. So in some instances, I find the same provider, private healthcare provider, in Singapore and Malaysia competing with one another for nurses.
That's right.
And that same applies to doctors.
Yes.
And we have the issue of contract doctors. We had the issue of housemen, housewomen, whatever, overworked.
Yes, right.
We have the other professionals, the biomedical engineers, etc., physiotherapists, overworked. So when we take the issue of talent bank in the healthcare, do we have adequate numbers? And if we have adequate numbers, are we compensating them well enough?
Yes.
And number 3, if we are compensating them well enough, are we actually running a sweatshop, just making them work long hours where quality drops? Number 4, how do we compete with Singapore just across the border,
Exactly.
or let's say with Saudi Arabia and
That's
Dubai?
right. That's right.
And this is the issue surrounding the talent.
Right.
Or in other words, the number of specialists. And I think last year we had the parallel pathway
Yes, right.
challenges, and there are multiple criticisms for and against.
That's right.
But the issue is, how do we address this in order to make Malaysian healthcare accessible, affordable, and more importantly, sustainable.
That's right.
And to ensure that structurally it's
Yeah.
meeting the needs of the country.
So because we are not only locally, we are facing, the public sector and the private sector, so very lucrative in the private sector. And how do we actually, continue to retain our doctors? That's the reason why we need to really focus on retention package in terms of make sure that, they are not overworked, they are well compensated in terms of their services. The pooling factor has been there since 1970s in the private sector. But many of them resign now is because of the pushing factor. Because of overwork, for example, less appreciation and the perks are taken away. On-call allowance, they're attempting to take away. Rural allowance been taken away. All this,
Can I interrupt, Tan Sri? How many of your children are doctors, Tan Sri?
only one.
Because they want a quality of life
That's
after
right.
seeing your life.
Yeah. So they are more towards business, right?
Okay. Sorry.
Very challenging for them. And now looking into healthcare, and the duration that we invest in healthcare education is actually long and costly as well. Undergraduate, postgraduate. To be a specialist like me, it takes about 13 years to start your career in breast endocrine surgery. So it's a long duration, and you certainly, we have to work in the early years before you can actually provide the care to our patients. So I think that's the reason why not many students wants to embark to become a specialist unless you really have the passion. For it.
Exactly.
So if you have the passion, by all means, go all out.
Of course.
But again, you must also have the funding in terms of that. I understand, once you become a specialist, if you have invested your education millions of ringgit, it's time for you to actually come back. But if your salary in the public sector is, not enough, for example. So obviously, once you have the experience and etc., you cross over to the private sector because you have a loan and to serve and etc. And also you need to repay back your loan and also the time with your family and etc. So I think these are the challenges that we have. I hope that the public sector can address the retention package for the doctors and widen the retention package so that they feel appreciated, not only specialist doctors as well as and nurses. Because in looking at our neighbors, they perhaps invest less in the education, but they pay more in terms of to attract our doctors and nurses there. So we are penny wise, pound foolish, I would say, because we spend millions training them, but not able to retain them. And they, across the border and etc., basically offer them, better pay, better salary, and then you can attract them. So I think it's about time for us to continue to highlight and address in terms of retention package for our staff.
Two things, Tan Sri. One is primarily, in the early 70s when I was a student, most of my friends who were children of doctors, they all became doctors. Because at that time it was seen as a very choice profession. But now, a lot of my friends who are doctors, I ask them what their children are doing, and 80% of them are not doctors. They are doing something else because of either the perceptions or what's really happening. Just going back to the second thing, having said that, there has been a shift in the profession itself being a choice profession. And that's why I think what Tan Sri says is so true. Unless I have the passion, I want to do really something, because I asked them, why did you become a pediatrician? And they said, well, I love children and I want to really take care of them.
That's right.
And then they went on to subspecialize on early born kids, and prenatal. And I thought that the amount of years that they spent was just amazing. I don't think there's an ROI on it.
That's right.
But having said that, Tan Sri, just moving on to another subject that kind of affected us and which has come back in recent times in education, is about parallel pathways.
Yes, right.
But just recently, I think the UK government said any degrees kind of outside of UK will not be recognized for work in the UK.
Right.
And that was a controversy with parallel pathway as well. They could be registered with the Royal College and they could practice here, but they could not go back and register in the UK or work in the UK.
Right.
Now, this has affected a lot of Malaysian universities now,
Right.
where, let's say, we do a completely UK program,
Yeah.
say 2.5 years,
Yeah.
and they can't go there. What do you think about this? I know it's politics in the UK,
Right.
but it affects livelihoods here.
Right. No, I think the recent issue is basically still recognized by GMC in UK, but the priority will be given to the local first.
Okay.
Then you can apply.
Okay.
And if there's no local taking up the job, then the priority
So
will be
it's
given.
like that housemanship foundation.
That's right.
etc.
That's right. So that is the issue they try to address. Otherwise, you are at par. For example,
For all practical
practical
purposes.
purposes. Yeah, I think that.
So
that's
what happens to Newcastle in Malaysia, or let's say the IMU degrees,
Right.
or Nottingham here?
Right. The degree is still recognized by GMC. There's no doubt about that.
Okay.
But priority will be given to the local
Okay.
university.
Okay.
And they are already New Met, for example. They are same degree, same education, same syllabus from Newcastle upon Tyne. But the only difference is in Malaysia.
Okay.
So same recognition, same degree, but the priority will be given to the local degree first.
Thank you, Tan Sri. I want to go back to something Tan Sri said is our neighbors and us, and maybe we are investing too much, and then they underinvest, but then they spend a lot more money to retain talent.
Yes.
But there's been a statement out from the government. Understand the context. Iran-US war.
Yes.
And I think it's become very challenging because we do not know when the war will end.
Yes, right.
Whatever the politics is. But the budget was cut.
Yes.
And the budget was cut for two sectors, which was education and health, which many of us think are the most important
Exactly.
sectors.
Yeah.
Completely understand that these are the ministries that have the largest budget allocation.
Right.
But don't you think that it's not fair to go and cut the budgets in those areas?
Yeah. So I think we look into it. We are already underfunded compared to other countries. But now, when you cut further, then certainly there will be impact in our services, research and training.
Sure.
So I think this is something that we need to really study which area you've been cut, and and 4 billion, now is about 3.8 billion. It's quite a lump sum.
You can't cut across the board.
Yeah,
right?
that's right. So we need to relook back again and hope that the government will relook back again in terms of cutting our budget. Hopefully, we need to come up with creative ideas,
Sure.
and to mitigate this situation in terms of reducing the funding to the Ministry of Health.
As we come to the close of the podcast, Tan Sri, I have two more questions.
Yes.
One question is, you were the face of Malaysia's response to the COVID-19 pandemic crisis. A terrible time because I myself lost my mother to COVID-19. There was applause and there was enough of criticism.
Yeah.
I'm sure you took it both in your stride.
That's right.
But the question is, have we come out of that crisis structurally from a healthcare system perspective?
So what we have learned from the pandemic COVID-19 is health is the wealth of the country. There's no doubt about that. And for the first time, I think, we need to leverage on the lesson learned from the pandemic COVID-19. And one of the important lessons is to optimize the resources of the public sector and the private sector.
Sure.
That's the reason why during the pandemic, we adopted the whole of government and whole of society approach. And you can see how two sectors can work together for the first time and to optimize our specialists, our equipment. Basically, we are not looking at sector, we're looking at the country response.
Sure.
So I think we hope that there will be some way, not during the crisis, that we still can optimize the resources for the public sector and private sector. So that's something that we hope that we can learn from that. And we know that today healthcare is transforming, evolving very fast. Digital health, for example, we talk about AI and automation, robotics, biotechnology is coming to play, and we need to adapt to this new ecosystem and environment. Question is, are we ready to invest in this system? How do we optimize the system? Meaning, invest in technology that we can provide better care and at a minimum cost. I think if that can be done, we can actually look into, improving our healthcare system. But we also need to shift the pendulum from curative to preventive care.
Sure.
So if we can have preventive
100%.
care, less patient in the public
100%,
hospital or in a private hospital.
100%.
So that is something. If you fail to switch off the tap, continue. You have to continue to build more hospital and the services will continue in the curative pathway rather than a preventive pathway.
I totally agree. I think preventive healthcare is the best. I think reduce your sugar,
That's right.
kurang gula.
Yeah, that's right.
And I think all the campaigns that go about stay active, etc., whatever the physicians tell you. Coming to the last question, Tan Sri, what do you think is the future of the Malaysian healthcare system? And if were three things, most urgent things that you think we should consider, what would they be?
I think we should look into our healthcare system, Malaysia healthcare system, not through public sector or private sector. We need to really holistic and then integrate the two systems together. Likewise, how we handle pandemic COVID-19, integration, whole of government, whole of society, and make sure that we optimize the resources that we have. And then we can cut costs, optimize into human resource, facilities, treatment, and etc. Not duplicating. When I was actually the chairman of a health standing committee for health emergency prevention, preparedness, and response, we look into the 5 things. Number 1, support the government of the day. That means support WHO. Number 2, avoid duplication. Sometimes there are a lot of duplication in the university, in the public sector, and private sector. If you want to do a research, if multiple institutions are doing the same research, for example, a lot of duplication. Number 3, you need to prioritize in terms of how, what to do and what not to do, prioritize. Number 4, and we need to focus in terms to achieve the target. I mean, say, for example, we are looking at prevention. Now, if we talk about prevention, the investment in prevention, we need to see a decline in the NCD, for example. That is a prevention, primary care, and etc. So it's based on facts and data. But today we see NCDs
primary
continue.
care is very important.
That's right, increasing. But the initiative that we introduce must be able to control or decrease the incidence of NCD. And last but not least, whatever we decide, it must be practical and it must be implementable. Then I think we can achieve the target.
Thank you, Tan Sri, for those five urgent actions you think we should take care to have an accessible, affordable, sustainable healthcare system. And I think also thank you so much for bringing this concept of preventive rather than curative. And I think it's very important to have a happy society, a well looked after society, so that people live in harmony and in unity. I think it's very important for us. The healthcare system has always been something between affordability, sustainability, public and private, expectation and reality. Healthcare, perhaps more than any other sector, Tan Sri, is really stuck in the middle.
Exactly.
So I think what we need to do is to look at what you said is a whole of society approach to make Malaysia where we believe that the wealth of a nation is in the health of a nation. Thank you so much for your time and thank you for being here, Tan Sri.
Thank you.
Thank you
very
so
much.
much.
Thank
Terima
you.
kasih.
Are you ready to become a change maker? Head on over to our Welcome Center or apply online today. We can't wait to see you on campus.
Subscribe now and tap the bell icon.